we will do kidney neoplasms. Kidney neoplasms and urinary tract neoplasm is the next one. So, tumors of the kidney. You can have 6 different types of tumors in the kidney. One is in epithelium, mesenchymal, neuroendocrine, pediatric. Secondary will be from lungs and melanoma. Pelvic tumor is urothelial. Okay. Epithelial tumors of the kidney, they are more common in industrialized countries. Risk factors of epithelial tumors of the kidney is obesity, smoking, end-stage renal disease, acquired cystic kidney disease, von Hippel-Lindau syndrome, which causes clear cell carcinoma. Hereditary papillary renal cell carcinoma syndrome causes papillary carcinoma. Britt-Hogg-Dubé syndrome causes chromophobe carcinoma, and tuberous sclerosis causes angiomyolipoma. This is very important. These are like the genetic mutations that are causing these carcinomas. Okay, now clinical manifestation is hematuria. Hematuria is the blood in the urine, flanks pain, palpable renal mass, weight loss, fatigue, fever, night sweats, and anemia. Staging, okay. For staging, T is for tumor, N is for lymph nodes involved, and M is metastasis. So there are 4 different tumor stages. You have tumor that is limited to the kidney but is less than or equal to 7 centimeters is T1. Tumor that is limited to the kidney but is greater than 7 centimeters is T2. If the tumor extends to major veins or peripheral tissue but not ipsilateral adrenal gland and beyond garrota fascia, so the tumor should be in major veins or peripheral tissue, but it should not go to the adrenal gland or the fascia surrounding the adrenal gland, then it is T3. If it is T4, the tumor extends beyond the gargota fascia and the ipsilateral adrenal gland. Okay. No metastasis to regional lymph node is NO. Metastasis in regional lymph node is N1. M0 is no distant metastasis. M1 is distant metastasis. Okay. Now grading. How do you grade a kidney tumor? There are 3 ways. One is Fuhrman grading, which looks at the nuclei. It's an old type of grading. WHO ISOP grading looks at the nucleoli, and it is the new type of grading. There are 4 grades, and grade 4 tumors have sarcomatoid transformation. Grade 4 tumors have sarcomatoid transformation. Now, treatment of kidney tumors is nephrectomy. You can either have it partial or radical, like the whole kidney. VEGF growth factor and tyrosine kinase inhibitors, vascular endothelial growth factor receptor, and tyrosine kinase inhibitors. Okay, anti-VEGF antibodies, mTOR inhibitors, and immunotherapy, checkpoints inhibitors, ipilimumab and nivolumab. These are all checkpoint inhibitors. These are drugs given as immunotherapy and radiochemotherapy. So you have nephrectomy, VEGF receptor, tyrosine kinase inhibitors given, anti-VEGF antibodies, mTOR inhibitors, and immunotherapy, checkpoint inhibitors, imilumab and nivolumab, and radiochemotherapy. Now, types of epithelial renal tumors. Types of epithelial renal tumors are benign. The benign types are metanephric adenoma, papillary adenoma, and renal oncocytoma. Metanephric adenoma, papillary adenoma, and renal oncocytoma. Okay. Papillary adenoma is the most common kidney tumor, and it is due to long-term dialysis. Okay, it is yellow tumor in the cortex of the kidney, with less than 5 millimeters of diameter. It is either papillary or tubular papillary in pattern. Then you have renal oncocytoma. It is less frequent in the cortex. It is palpable, hematuric, okay, mahogany brown, grayish radical central scar, sheet like or is island formation. Okay, cytoplasm is rich in mitochondria. Fine. Now, the three malignant types of kidney tumors are clear cell renal carcinoma, papillary renal carcinoma, and chromophobe renal carcinoma. Clear cell renal carcinoma is the most common histological type with 70% to 80%. Pathogenesis, the mutation in one Hippolyndau gene on chromosome 3, loss of VHL, increases hypoxia inducible factor, which increases VEGF formation and other factors, which causes uncontrolled cell division, which leads to clear cell carcinoma. Now, macroscopically, it is well circumscribed with yellow brown color. Areas of hemorrhage, necrosis, and scarring. Okay, high in fat. Advanced cases, tumor invades into pelvic or perirenal fat. Extension of tumor into renal vein, vena cava, and also the right atrium. Microscopically, you have abundant clear cell cytoplasm, lots of glycogen and lipids. PAS and Sudan are the staining used. It's either solid, trabecular, alveolar, or glandular in structure. Cancer cells are surrounded by a rich network of capillaries. There is necrosis, hyalination, cystic change, hemosiderin deposit. Metastasis mostly hematogenous to lungs. And then you have it also in the bones, CNS. Lymphatic is rare. Mostly it's hematogenous to the lungs and also to the bones and CNS. Lymphatic is rare. Then you have papillary renal carcinoma. It is the second most common histological type. Clinical manifestation is similar to clear cell carcinoma. It is multifocal or bilateral. Size cutoff between papillary adenoma and carcinoma. Remember, papillary adenoma was benign. Papillary carcinoma is malignant. So, what size will determine if it is papillary adenoma or carcinoma? If it is less than 15 centimeters, it is papillary adenoma. If it is more than 15 centimeters, it is papillary carcinoma. Okay. Prognosis is favorable. Macroscopically, it is a densely arranged papillae. Higher nuclear grade is more aggressive. 2/3 is hemorrhage and necrosis, 1/3 has calcifications. Type 1 is papillary growth with small cells and small cytoplasm with hemorrhage, foamy macrophages, and cholesterol crystals. Okay, type 2 has large cells with eosinophilic cytoplasm and more nuclear atypia. Okay, and then you have chromophobe renal carcinoma. It is the third most common, similar to clear cell carcinoma. Okay, favorable prognosis is favorable. Light brown with hemorrhage and central scar. Pale cytoplasm with resinoid nuclei. Okay, seen in Britt-Hogg-Dubé syndrome. Positive Hale reaction is just colloid iron. Okay, that was it with the epithelial tumors, which is benign and malignant epithelial tumors. Now we will do mesenchymal kidney tumors, which is angiomyolipoma, hemangioma, lymphangioma, leiomyoma, lipoma, sarcoma, reninoma, lymphoma. They're all mesenchymal kidney tumors. For angiomyolipoma, it is a benign, common yellowish mesenchymal tumor of the kidney. Multiple lesions seen in tuberous sclerosis. Okay, others are sporadic. Then it is a part of pecoma, perivascular endothelial cell form. Tumor contains fat, smooth muscle, and blood vessels. Everything that is developing from a mesenchyme. Mesoderm, sorry. Then you have neuroendocrine tumors, which is rare, uncommon, has characteristics of both nerve cells and hormone producing cell. Pe- Pediatric kidney tumors are Wilms tumor, clear cell sarcoma of the kidney, rhabdoid tumor of the kidney, and congenital mesoblastic nephroma. Wilms tumor is 80% of all pediatric tumors for between 2 to 4 years. Precursor lesion is nephrogenic rests, relation to nephrogenic blastema, seen as a mass. Okay, now it has three types of cells: epithelial, blastemal, and stromal. The epithelial cells are immature kidney tissue, completely undifferentiated. Blastamals are completely undifferentiated small round cells. Stromal are immature mesenchymal tissue or heterologous differentiation. Secondary metastasis is from lungs and melanoma. Pelvic tumors are urothelial.